Welcome to our kidney support group. Everyone here is pretty passionate about kidney care. The competing panel was about eyeballs. So you've chosen, it was an ophthalmology panel, so you've chosen kidney care. But seriously, everyone here on the panel is very passionate about care for a very deserving group of our population, folks suffering with chronic kidney disease. My background, I'm actually a venture investor now. I initially started my career as a physician, but venture investor at Flair Capital Partners. We're a Boston-based venture capital firm. We only invest in healthcare software and services. Full disclosure, I'm biased. We're investors in Samadhis. We're big fans of the company. We're also, as a firm, we're lucky to have large healthcare corporations who invest in our fund, and so we're lucky to have the Cleveland Clinic as an investor in our fund as well. But before that, I was a practicing internal medicine doctor, a hospitalist at the Mass General Hospital, and I saw firsthand how many patients struggling with end-stage renal disease and chronic kidney disease had a very large medical burden, a very large social burden, and often didn't have the help and the resource in order to deal with that. When we were kind of doing our panel prep, Dr. Wong mentioned that we should probably level set. Everyone here on the panel has been eating, breathing, kind of drinking kidney care for the last several years, but many folks may not be at the same level. And so I've spent the last 2 years learning about kidney care, and I'm going to try and distill this into 2 minutes for you. So I'm going to start off with some high-level macro statistics on kidney care today, and then update you on what happened earlier this summer in July when the Trump administration announced the executive order for advancing kidney health. So high level, there are 37 million individuals in our country living with chronic kidney disease, and 700,000 of those individuals have end-stage renal disease. The total cost of care for this population for our country is around $200 billion, and then $40 billion alone are the costs of dialysis alone. CKD, as you may know, is a silent disease. It oftentimes does not have symptoms. 40% of patients with CKD don't even know that they have it, and interestingly, it's that same number, 40% of chronic kidney disease crash into dialysis. They crash into end-stage renal disease. And then when you think about patients who have end-stage renal disease who are getting dialysis, only 12% of those populations have access and are actually getting home-based therapies, peritoneal dialysis and home hemodialysis. If you compare that 12% number in the US to other developed countries, you have these other developed countries have rates around or above 30%. So there's this almost threefold difference between the US rates of home-based therapies versus other developed countries. There is no cure for end-stage renal disease. The cure is a transplant. It's a kidney transplant. That's another situation that has a lot of challenges. 100,000 patients are currently on the transplant wait list today. That average wait time is 5 years. A very, very sad aspect of end-stage renal disease is the high mortality rate. The 1-year mortality rate for patients with end-stage renal disease is 20%. The 5-year mortality rate of patients with end-stage renal disease is 65%. So in many ways, for many patients with end-stage renal disease, it is a death sentence. And in that backdrop, 2 extremely large companies have gained almost 85% of total market share for delivering dialysis services to the population. Anybody know who 2 of those companies are? DaVita and Fresenius. Excellent. Our audience is up to date. So that was the backdrop. So in that climate, the Trump administration, mainly Secretary Azar, Administrator Verma, and Adam Boehler, who was the head of CMMI, announced their Advancing Kidney Health Initiative. And it was an executive order. It wasn't, a piece of legislation. This came from the administration themselves. So it speaks to how important and how imperative they thought this was. They announced 3 major goals for the executive order. They wanted to reduce the onset of end-stage renal disease by 25% by 2030. They wanted 80% of new patients with end-stage renal disease either to have access to a home-based therapy or to get a transplant, which is a remarkable number. And they wanted to double the number of kidney transplants. How do they plan to do this? Well, how does CMS do anything? They change how they pay for things. That's how CMS gets things done. So the first thing they did is they completely changed and overhauled all the incentives for the organ procurement organizations on how they get scored and how they get rated to acquire donor kidneys. And they actually removed penalties. It was quite surprising that there are actually penalties. If you want to donate a kidney, there are these perverse incentives that these people are affected by, and they've completely changed that. They also created 5 new payment models. 1 required and 4 optional for how kidney providers get paid. So the 1 required is they changed all end-stage renal disease dialysis payments and tying them to the penetration rates of home dialysis and the penetration rates of transplant. So that's the first time that's ever been done. And then they created 4 optional payment models that allow nephrologists and other risk-bearing entities to get upfront capitated or risk-bearing payments that lead to overall outcomes for this population. So that's the backdrop. I spent 2 years in 22 minutes, so hopefully folks are up to date now. So with that, I want to introduce our panelists. Akena Okezi, please talk a little bit about your own personal background and why you started Samadhis and what you're focused on.
Sure. Thank you, Dan. And thank you all for welcoming us here. So I'm Akena Okezi, and I'm co-founder and CEO of Samadhis. And as Dan mentioned, he at Flare Capital is an investor in us, so I'm biased as well, so I really like Dan and Flare Capital. So Samadhis is a disruptor. So Dan mentioned that there are 2 large players. It's essentially a duopoly. There are a handful of others, so US Renal on the services side, US Renal, ARA, and a handful of others. Samadhis is not a fee-for-service dialysis provider. We're a value-based kidney care provider. So our role is, as a managed benefit provider, we approach health plans and payers and health systems, and we essentially carve out the risk for CKD and ESRD, and we bear it on ourselves. And then we only make money when we keep patient populations healthy. So we have metrics like delaying CKD progression, because if we can keep a patient off of dialysis, then we get higher payments in terms of shared savings. And we have metrics like we don't want patients to have central venous catheters and temporary accesses, and we prefer that they do home-based dialysis, either peritoneal dialysis or home hemodialysis, because the longevity is better, and also they tend to stay and stay healthier on those programs, and they cost less for payers. So our model is essentially we bear risk to manage patients under delegated risk with health plans. Because we thought it was important to be a full services provider, we also provide dialysis. So we do home-based dialysis. We've opened several clinics. We're based in Virginia. We've opened clinics in Virginia. But then we also do inpatient dialysis, because we thought when we first got started, it's really important to, if you're disrupting a really big market that's traditional fee-for-service, you've got to have proof points. And the first proof points that we thought we could get were on the inpatient dialysis side. So we're actually the largest inpatient dialysis provider in Northern Virginia, 5 hospitals in a system called Innova. So I'll just stop with that and say, by way of background, I'm a physician by training. I went from med school to business school at Harvard to McKinsey & Company, and so I was a consultant for several years, then the advisory board company, and then DaVita for 5 years in the DC market, where I ran DC, Maryland, Virginia, and North Carolina. So that's my background in a nutshell.
Perfect. You can see why we invested in the company. We're super excited. Leslie Trigg, CEO of Outset Medical. For the group, please talk a little bit about your background and talk about your exciting company.
Sure. Well, I like Dan as well, although he's not an investor in Outset. So I come from the devices world. I heard the last panel talking a little bit about device development. So that's my world. I don't have a background in dialysis. Most of my career since business school has been spent in the cardiovascular space, developing devices for coronary and peripheral vascular disease. And I got involved in dialysis through a private equity firm, Warburg Pincus, that had made an investment in this company, Outset Medical. The idea from the get-go with respect to Outset was to try to develop a device that could decouple dialysis from infrastructure. The last truly novel device that was developed and approved by the FDA was in 2001. So this is not a space that's seen a tremendous amount of innovation. We might touch on that theme again. It's been a very, very long time. And when you think about policy changes within the executive order around home, today there is only one device that's been cleared by the FDA for home, and that approval came in 2005. So it's been a long, long time without a lot of choice for patients, and without, we believe, not necessarily the right or an optimal technology that offered more flexibility and convenience. And so the problem, I heard the last panelist talking before, it's always a good reminder, what problem are you trying to solve? as an entrepreneur. And the problem that we were trying to solve from the get-go was, how do we reduce the cost and the complexity of dialysis wherever that's delivered, whether that's in an acute setting, in the clinic setting, or at home. So that's what we set out to do, and where we thought we could have an impact in reducing the cost and the complexity of care.
That's excellent. And then finally, we have two Leslies on the panel for our purposes today. Dr. Wong, I'll refer to you as Dr. Wong. Talk a little bit about your background. You're a kind of staff clinician here at the Cleveland Clinic.
Yeah, absolutely. And again, it was an interesting planning call with two Leslies on the phone. And again, congratulations, Leslie, to your to Outset's Kidney X Award. That was wonderful. So I spent the first 6 hours of my day today actually taking care of patients, home dialysis patients, listening to their fears, their frustrations, congratulating them on their successes. So I think I kind of bring that perspective to the panel. What do I do in my spare time? Well, I'm Associate Director for our Medicare Accountable Care Organization and work in our value-based contracting team. So, firsthand understand the complexities of all the changes in legislation, all the promise and all the opportunities that we have. And again, as Dan mentioned, with potentially dramatic change in reimbursement in the United States, we're looking at the most pivotal time in the kidney world since 1973, when Congress approved universal coverage for dialysis. So two landmark time points in our history. I am the director of end-stage kidney disease at Cleveland Clinic, and along with my colleague Robert Heika, we manage a very large joint venture with one of the large companies, Fresenius, and we have for the past 2+ decades, and perhaps a little more, Kenna. Have a lot of insight in the challenges of partnering with a large organization, but also a lot of the opportunities as well. Prior to that, I was Vice President of Clinical Affairs and implemented the CMS quality program at a company called Satellite, which is one of the largest nonprofit dialysis providers in the country, and then started my career as Director of Home Dialysis at Northwest Kidney in Seattle, which was the birthplace of outpatient dialysis. So not only do I have a kind of a keen appreciation of all the things that are going on in terms of the medical landscape, but really had the benefit of learning about the history of dialysis and the history of kidney failure, something that I will never take for granted.
Mm-hmm.
Well, it's really, really fabulous. So I want to keep, we've got a nice intimate group here. I want to keep the panel very interactive. I have a handful of prepared questions, probably do about 4 or so for our panel, but then want to encourage audience Q&A perhaps earlier than I think we traditionally do it. So Ken, I want to start with you, but then again, want everyone else to kind of chime in here. We kind of just ran through the executive order. When you think about, the world 2 to 3 years from now, who are the winners and who are the losers in this new world of how we reimburse for kidney care?
It's a great question. I'm actually curious, just in the audience, by show of hands, how many people have heard of this executive order for advancing kidney disease? Okay, great. So nearly everyone.
We're preaching to the choir.
That's great, yeah. So
our support group.
So I'll share my perspective. I'm sure all of you have your own perspectives on this particular question. So the executive order, essentially, with the optional programs that are available in the executive order, creates a new contracting mechanism for nephrologists and health systems to connect directly with Medicare in what we would describe as like a Medicare Advantage Lite program. So it's a disintermediation of existing dialysis fee-for-service providers, because it explicitly says kidney contract entities do not need to include dialysis. Now, they could include dialysis organizations, which is great, but if they don't have them, they don't need to, which means small nephrology practices with one nephrologist could do a contract over their ESRD and late-stage CKD patients together with a health system that's interested in doing more kidney transplants and contract directly with Medicare. I think that's amazing, because what it does is it creates a big financial incentive for people to manage late-stage CKD and prevent that progression. And when they do well, then they benefit from it. So who are the winners and losers? I would say if you're a patient, then you're the #1 winner in that program, because it's going to reduce your likelihood of progressing through late stages of CKD to ESRD. And if you're in ESRD, there's going to be a pretty big push to get you transplanted and to keep you out of the hospital, right? So those are very big economic wins for the executive order in that program. Now, certainly if you're part of the kidney contracting entity, so if you're a nephrologist who, you all probably are familiar with the economics of fee-for-service dialysis. If you start a dialysis business or a center, it might take 5 years to get to a census of about 70 or 80 patients, at which point you'll have an EBITDA of about $1 million. And if you have half the clinic as a JV partner, you might make $500,000. Now, that same nephrologist with 1,000 ESRD patients costing Medicare per member per year of about $100,000, that's $100 million in expenses under management that a nephrologist could manage. And if they reduce that cost by the average that the ACOs did, the renal ACOs, that's about $5 million. So Medicare takes half, the nephrologist takes half, that's $2.5 million. So in year one, they could make up to $2.5 million in savings by implementing this program. So nephrologists can really win in this program. And then health systems can really win in this program, because if a health system is interested in transplants and you partner with a nephrologist and you become a kidney contracting entity, then those transplants go to the health system that participate. So I think the losers may be, dialysis companies that choose not to participate for one reason or another. It's not exclusive of dialysis companies, so if they choose to participate, they can participate too. But if they chose not to, then that could be a losing entity. And then to a certain extent, health systems, if they're not participating in accessing the new transplants that can come from a program like this, then seeing the reduction in the hospitalization that's likely to come from these kidney contracting entities could reduce the amount of flow coming in and out of the hospital.
No, that's great insight. Leslie, how do the folks at Outset, how have they embraced this new legislation?
Well, do you mind if I put a slight twist? I wanted to answer your first question and sort of make a pitch to maybe both investors and entrepreneurs in the audience about who I think could win. So this is in the future. I'd really encourage you to take a look at investing in the renal space. It's not a space that's had a lot of capital flow going into it. And we need more. I think sort of stagnation begets stagnation. And there are a lot of reasons why not more capital is flowed into, certainly device development, a little bit more on the drug side. But I think the executive order could be a really important stimulus that would be more compelling, make it more compelling to invest in renal than it has been in the past. Here's why. As part of kind of an add-on around the executive order, we finally have the potential for a new technology add-on payment for the first time. So anybody who's ever invested in spaces outside ortho, neuro, cardiovascular, you might be aware that both inpatient and outpatient, there has always been, or not always, but for many, many years, there's been a new technology add-on payment that allows a provider, a health system, a hospital, to get incremental payment for using new technology. It covers typically 50 to 60% of the cost of that new device or the new procedure. That's never existed in renal before. That's being proposed for the first time. By and large, yes, it needs some tweaks, but it has a lot of promise. If that goes through and is published as part of the final rule, I think that will be helpful in giving investors a little bit more confidence that if you invest the capital and the time, by the way, typically, that's an 8 to 10 year investment from concept to commercialization, that companies can be successful and that it might be a more hospitable environment than it has been in the past for the adoption of new technologies. So I think the winners could be investors and other startups. And please come in. We need more. We need a lot more. I think we are working on an FDA clearance for home. If we get that clearance, there's only to be 2 companies in the home space. There is plenty of room for more and better devices, not only for home, but for dialysis and the patient experience across the board. So please come over. You will be welcomed.
That's excellent. Dr. Wong, I mean, you're unique. You've worked for very large organizations, but as a nephrologist, you're focused on home dialysis. So unique in your cohort of nephrologists. How do you see this executive order kind of playing out?
Yeah, absolutely. The only thing I'm not unique is that I'm underpaid, right? So, but actually, I think these comments are wonderful, and I'd like to add, I think this is the time where there is a true sense of urgency. In the kidney community. So not just amongst the dialysis organizations, kind of the traditional kind of bulwarks of care for our kidney patients, but I think within healthcare systems, I've certainly seen that on the ACO side. talking with payers. They're very, very interested in what's going on because at the end of the day, you know, there seems to be this huge discrepancy between the cost of care for an average beneficiary and patients that have not only ESRD, but CKD as well. So I think it's, you know, there's a lot of interest, there's a lot of anxiety, but I think ultimately this is the time where we can really meld a lot of the things that, that Leslie has really alluded to in terms of technology, how we interface that with also kind of our core care, right? So a lot of that, like I alluded to when I first introduced myself, you know, being there for our patients, that face-to-face encounter, those things are, you know, can't be minimized. But I think as you look at health systems, as you look at the providers, as you look at physician groups, there's this opportunity to align, because I think when you talk to the leaders of even the traditional organizations, you know, quoting Alan Nissenson and Frank Maddox from this August, I mean, they've actually been very interested in moving in this direction, but the reimbursement has kind of constrained the system and how it's been able to evolve. So I think those constraints are kind of off, because I think to your question, Dan, I think Medicare has been very clear who's going to lose on this. People that don't change, up to the tune of $169 million in 2026. So there's real money on the table. And I think that's actually a good thing. So.
Absolutely. So Leslie, we're here at an innovation summit, so we can't lose sight of the fact that there are two startups, albeit well-funded startups, on the panel, but are going up against very large, dominant existing stakeholders. As an entrepreneur, Leslie, how do you think about kind of going up against these well-resourced organizations who have endless amounts of capital to throw at a problem?
Thanks for that ego boost. I appreciate it. Thank God you're not on our board.
Your price is way too high for us.
I'm not even going to comment on that. So I think if we had thought about designing the same thing with the same features, the same benefits, the same size, the same color, then I guess I would consider them to be competitors. I think, and this is probably a very, very basic statement that applies to any startup, we tried to start with, again, what are the bigger problems to be solved? What doesn't exist, whether that's for patients, physicians, clinicians, other, and then how do you fill that space? And if you can get there, and figure out how to solve a problem that hasn't been solved or how to invent something that doesn't exist, then I'm not sure they really are called competitors. Now, you come crashing, that's in the development part one. Then you get your FDA clearance, and then you crash into the realities of the commercial world. So I would be lying if I said that there were not, certainly not drawbacks to competing against large multinational corporations, even though we've been pretty well funded and we've had the opportunity to invest the right amount of money at the right time. I think some of the disadvantages are, they have an existing global footprint, field service engineers and sales reps, and clinical data, and having been around for maybe 15 or 20 years in the device marketplace. As you guys know, Fresenius also is vertically integrated. They make machines, Next Stage, Baxter, others. We don't have a way, they have ways that they do things. Most startups don't have the way that things are done. They don't have a way that anything's done. You literally are starting from scratch and recreating the wheel over and over and over again every day. We don't have a way that we do things. Now, on balance, I would say that's more of an advantage. We are preparing homemade food, not fast food, so it's not going to happen overnight. But I think, like a homemade meal, we have a lot more latitude to experiment, and we have a lot more latitude to throw it away if it doesn't taste good and do something else, and the stakes are pretty low. So we do a lot of iteration, we do a lot of experimentation in really small ways before we go big. So that's one way. I think we also have because we have the freedom to create, and we don't have a way that we do things, we've brought a lot of people in from outside, forget about outside of dialysis, most of Outset is not from, we have one engineer from Baxter, that's it. So we have not only hired outside of dialysis, we have hired outside of healthcare. We have team members from a ride-sharing service, not Uber. We have a person from the airline industry. We just hired somebody from a theme park. I mean, it's a diversity of experience, and I think will lead to a cross-pollination of ideas in ways that might be harder, not impossible, for a big company to recreate. So I think we are advantaged there, and the fact that we really are not afraid to lose. one time. And I think when you can lose the fear factor of failing, it just gives you a much wider band of freedom to create. And sometimes those experiments will succeed. Not always, but we don't have a big fear of failure. And I think that's maybe the biggest thing that advantages us is we don't have a lot to lose, and big companies do.
And I mean, your product is so differentiated. I might ask you to talk a little bit more about it. Before I had the panel, I went and I Googled Outset Medical, and I saw a lot of articles featuring Leslie. And I don't know if you came up with this phrase, but you guys call yourself the Tesla of dialysis machines, and you talk about your focus on kind of consumerism and the ease of use. Maybe talk a little bit about how you're thinking about the product from the consumer's perspective and their ability to try home dialysis.
Well, one, I'm really regretting I ever said that. So thanks for bringing that up, because I think it was like literally the next day Elon
That was before he was on the radio.
Being investigated by the SEC, and like people talking about him doing drugs and stuff. Anyway, so let's move on. But no, but I think what we have tried to do, maybe said a better way, is incorporate principles of consumer design. That's really what I was trying to say. And the way that we design products for us as consumers is, with our observation, is entirely different than the way that dialysis machines have been thought about in the past. And so all we really tried to do was think about how do we make this super, super, super simple, and then how do we integrate data. I'm sure there's probably tomorrow 100 million talks, and I'm not going to use the words AI, but just the simple act of embedding two-way wireless data transmission, you can get a ton of clinical information, machine data, longitudinal clinical data by clinic location, in the hospital, in home, in the outpatient setting. There's so much to be learned, and prior to pretty recently, dialysis was really one of the few aspects I think in clinical medicine that was pretty well disconnected from information. And so all we really tried to do was think about this as a consumer product first and a medical device second.
That's great. Ikenna, I'd ask you the same question about competing with very, very large, dominant existing stakeholders who you know well, who may be in the audience because the Cleveland Clinic Summit is well attended. What are your thoughts? I know I have my experience, but what are your thoughts?
Sure.
I
really like something that Leslie said around not having fear. So number one, it's just you have to assume that you're going to take some losses and just be prepared for those. And I think we're prepared for it. One of our core values is tenacity. And so we actually have a saying at Samadhis. It's you can beat us up, but you can't beat us down. So we get beat up a lot, but you just kind of keep going, and you get wins, and those wins ultimately accumulate to be big enough for the world that we live in. So the dialysis industry, as you said, together with non-dialysis costs, is a $200 billion market. So we don't have to win big to survive. We don't have to win big to even thrive. But you have to be, some things that come along with size are actually lack of agility at times. And so we're very agile, we're quick to respond, and we're very flexible. So I think that those things come to our advantage. At the same time, I think the big companies have a lot going for them. And, like Dr. Wong said, the payment mechanisms have not been structured to help them essentially innovate in ways that, you've heard about so far on this panel. But those are changing, and we'll be prepared, and I'm sure they'll have responses too.
Yeah, no, it's well said. I mean, again, from my experience investing in Samadhis, we've kind of been on this journey with them for 2 years. You've been on the journey a little bit longer, separately. There are a lot of misaligned markets within healthcare that have misaligned incentives. It's not just kidney care, but you can have these misaligned markets and they can remain that way for a really, really long time. And so I think as an investor, it's oftentimes looking for where are the catalysts, where are the burning platforms, what's going to force entities to change. And sometimes you get lucky, right? I think when we first heard the Samadhis pitch, it was glaring how misaligned the incentives were and how big of an opportunity there would be if risk-bearing organizations, specifically health plans, potentially health systems, but really about health plans, those entities that are paying the cost, if they were able to switch over to a new model of care, how much benefit they could have. And so, you had an early adopter, an early pop health customer, but once the executive order changed, to me, it was the burning platform where all the managed care organizations basically said, the future is coming, maybe a few years away, but we need to get on board now. And Samadhis was a dominant player in that space. And so that's kind of been my perspective on, working in these dominant industries. Dr. Wong, I mean, you kind of described yourself as a paradox in our early pre-panel conversations, and that you're, relatively young individual, early career clinician who's working at these very large existing corporations. So maybe talk a little bit about how it feels to be in one of these organizations. How easy is it for them to change? How does it feel to be a dominant existing stakeholder as there's all this disruption kind of happening in the midst of your backgrounds?
Yeah, no, thank you. I think there's no, there's no doubt that as a startup, a smaller organization, an entity that's young in its life cycle, you are more nimble. You have the ability to take more risk. And there are a lot of advantages that go with that, and especially on the technological side. On the other side, though, when you have a mature organization, you have stability, you have resources, you have scale, you have history, and I think importantly, you have relationships. And I think the one thing that I've learned, whether you're in a small organization or a large organization, the importance of trust and relationships, not just between physicians, but between other stakeholders in the medical space. I think that as we look forward, it's, I think looking at how we can create value along different dimensions and along different axes, I think that's going to be important, because ultimately the people that we're really interested in expanding value for are our patients. And so how do we enable, how do we facilitate that? Well, I'm in a leadership position right now for one of the major initiatives for the American Society of Nephrology, something called NTDS, Nephrologists Transforming Dialysis Safety. And so I think as physicians, we've always kind of hinged our strategy on, well, what's the best evidence? Do the best trials, do the best, do the most scientifically sound approach to medicine. We recognize that's only part of it. The other part is actually human factors. So that has a lot to do with not just workflow design, but how do we better and best integrate technology in an optimal way so that we not only get the data that we need to make the right decisions, to make informed decisions, but how do we enable our caregivers to actually do the job that they're supposed to do? And some very simple things that you'll see on the technology side. So interface, right? That was never a consideration. It was like, it's all compliance, right? We have all these buttons and all these alarms to make sure that we're compliant. But we've never really thought about how do we actually make people excited to interact with the machine, because ultimately it's not just the machine, it's the person. So that's the second part. And I think the third part is how do we develop the right mindset, right? So when I describe myself as a paradox, it's because many physicians, we were never trained. We're classically trained. You guys had it right. You went to business school first, right? Many of us figured out that we don't have the skills to actually not only manage people, but to manage ourselves. So I think that paradigm is changing, and I think the reimbursement, the innovation, the technology, all this is going to enable us to create more value for ourselves and for our patients.
That's excellent. I'm going to have one more question, but I want the audience to start to think about questions. I'm going to kick it to you guys in a second. And I keep this open to the whole panel. What's been your experience working with these, kind of patient-delegated organizations, so large health systems, large payers, as it pertains to kidney care? How have they embraced you? What has been, their overall motives? How have they been as partners? Maybe we'll start with you.
Yeah. So we have been blessed, frankly, to have a really strong health system partner in Virginia called Innova. And they were doing a request for participation and for proposals, and we did it, and we won. And I'm amazed that they took a chance on a startup. So we didn't have the history, we didn't have the results, and we were just 3 people in the organization at the time. And they were very progressive, and they took a chance. They took a chance on us in working on outpatient dialysis, creating joint venture outpatient dialysis units. And then we together decided to work on inpatient dialysis. And so now we have 5 hospitals, and we've gone through 10 surveys with the Joint Commission and CMS and the State Department in Virginia, and they've all gone well. But to the health system's credit, when we transitioned that agreement from the previous provider, 2 days a week for 3 months, they dedicated a small team of people to actually work with us. And we'll never forget that. So I think it's if you want to see change happen in a field where there hasn't been a ton of change, it really does take progressive customers as well as progressive organizations and entrepreneurs. And So, and I think there are many health systems out there like Inova, and I've heard a lot of great things about the Cleveland Clinic and many others. And so I think that role of having a progressive system is very important.
What about health plans? What's kind of surprised you about engaging with health plans around this concept of ESRD, CKD, and having done so for the last 2 to 3 years? You don't have to name any names.
Yeah.
What's been surprising there?
Well, I think the biggest surprise I've had is when I was in a large dialysis organization, we thought the health plans had all the leverage. But now I'm outside of it, and the health plans feel like the large dialysis organizations have all the leverage. And so they're looking for solutions to help with network adequacy for dialysis or get better rates. And if you know anything about fee-for-service, Medicare reimburses at about $250 a treatment for dialysis, and the average commercial plan is at $1,000 per treatment, somewhere in that neighborhood. So it's just surprised me. But in working with health plans, I find that they are more than I used to think. So 20 years ago, I was in the health plan space, 20 years ago. Now, I didn't do much then, but now that I've gotten a lot more involved with health plans, I've realized they're very involved as providers. And that's something that's really surprised me, is that they're very interested in taking a long-term approach and building out primary care and building out specialty programs, and we welcome that as a provider.
And I mean, I think that's a recent shift, right? I think health plans are starting to think about, having worked at a health plan, is what is our value proposition? How do we not get disintermediated, disrupted? How do we, start to blur the line between payer and provider? Leslie, your thoughts on working with some of these large, kind of patient-delegated entities, health systems, health plans as you're developing your device?
Yeah, I'll start with the health systems. I guess my one-liner would be drink of water in the desert. Thank God. I mean, yeah, progressive would be exactly the right word for it. So, why? Most hospitals are constantly adopting new technology. So it was like the first time we stepped into our first hospital, it was kind of like old home week. Like, oh yeah, yes, there are people who actually want to welcome new devices and think more open-mindedly and also use things that may be at relative stages of proximity to ready for prime time. We were talking about this before the panel. The Cleveland Clinic was not only, I wouldn't even describe them as an early adopter, they were truly like the Intrepid. They were like the pre-early adopter with the first generation of our device, which is very different than the second generation of the device that we use today. And there's just only so much you can learn with any device in the lab, where it's not interacting with patients and not interacting with users and a broad diversity of different types of users. You unfortunately just reach a point with any device, you've gotta put it out into the world. You have to say goodbye. It's got to go to college, and you're going to learn a lot that first freshman year. That was our experience here at the Cleveland Clinic, and there were a few others that were the bold and the brave. And it does take, again, it takes a lot of courage to use something where there isn't a 20-year track record. There are not 50 other customers that you can call for references. You have to go out on a limb on your own. And help the companies learn, because that's the only way the devices get better. So health systems like the Cleveland Clinic have been absolutely instrumental to our ability to make that device better and better and better for patients. Quick note on payers, I would describe their mindset right now as highly frustrated and extremely motivated to change the way that they deliver dialysis to their patients. I think we're going to see a lot of payer-directed dialysis care.
Yeah, and I'd just like to follow up on that. I mean, with the 21st Century Cures Act, in a very short period of time, we anticipate up to 40% of ESKD patients may be on MA plans. And again, like right now, they're ineligible unless they start out with that. So I think the time is ripe in terms of not only new ways of thinking about how we care for our patients, but how we collaborate with payers, with the organizations, with startups, and actually with other members of the healthcare community. We've been I think we've been guilty of being very insular in the kidney world, in part because of the structure that we're in. But I think as not just the payers, but health systems, the public, and patients become more aware of all the different opportunities that are out there, I think it's going to stimulate a lot of diversity of thought. And I think getting to what you said, Leslie, and what we talked about, some of the ideas and some of the best things that we learned about your device did not come from physicians.
Right.
They came from nurses, from technicians, from people who actually we're working with the
Absolutely.
machine. So yeah, so there's a lot out there.
Yep.
Perfect. Want to get some audience for some questions? Yeah, right up front.
Could you speak to the current state of the application for your annual use?
In a limited way, yes. So the results from the clinical trial have been really encouraging, and the relationship with FDA is good. We've been really happy with the progress, and I would call it a near-term versus a longer-term event. But I've long since learned not to try to stare into the FDA crystal ball about when things are going to happen. But we've been really happy with the progress.
Perfect. Yeah, front.
So home-based care is going to be a driver for change going forward. I guess, do you see that change being driven more by home chemo or home PD? And how are the big players
Do you want to answer that first?
Yeah.
kind of respond accordingly, tactically, given they have so much infrastructure already in the dialysis centers across the U.S.?
Yeah, I'd like to take that question. So one of the things that's important to do when you kind of conceptualize dialysis care is that it's easy to kind of say, well, home dialysis is better, so we should really just kind of put all of our, apples in that bushel. But really, it's a continuum. And again, like I said, today I talked with and I cared for home dialysis patients. It's not easy, okay? But it's very rewarding. But many of those patients actually transition in and out of the centers. So having that infrastructure to make sure that they're successful at home, but also to take care of these unexpected things and these transitions, I think that's really important. And so I think you have to have a broad-based strategy.
And I would just add to that, so part of that broad-based strategy, which historically has not been very available, is having an economic model that allows you to put caregivers into the home alongside patients. And so, when you do what's called staff-assisted home hemodialysis, it helps patients who otherwise would have to self-cannulate, who maybe they don't have a caregiver to do it for them, to have someone from, our team or somebody else's team to go into the home and help them do that. Now, that's an infrastructure that is hard to do under traditional fee-for-service economics for dialysis. But when you take total cost of care on a patient panel, and instead of getting $250 or $300 of treatment, you're actually getting the equivalent of $100,000 per member per year, then it allows you to make investments that would help get a patient from in-center hemodialysis into the home. And it doesn't have to be home hemodialysis. It could also be peritoneal dialysis, and be an extension of what a nephrologist or a care team could do in a center. You go into the home and you help patients, and then you use devices. It's perfect because the timing of these devices that do this bilateral communication, where you can actually read and see whether or not the dialysis treatment is adequate, you can do that from a distance. So those are some of the trends that will help drive home dialysis.
That was excellent. The conference organizers are going to get mad at me. They're looking at me in the back if I go over time, but we're at time. I know our panelists will stick around to answer any more questions, but thank you so much. And please welcome me in kind of thanking our panelists for this. This is great job.